foremost of maternal killers and can kill even a healthy woman within 2 hours if not treated. So PPH accounts for 38 to 53% of maternal deaths in different parts of India, and in many cases PPH is unpredictable. High parity and hope delivery brought late due to varied reasons with pre-existing anemia are the common problems on analysis of maternal death due to PPH. Sometimes even in the best hands with the best facilities too, death due to PPH cannot be prevented. The requirement of lots of different types of blood and blood products, ICU facility in remote areas are the major obstacles in preventing death due to PPH. And death due to PPH is mentioned in books and medical literature, even in the best facilities and even in developed Western countries too. So the solution is that we have to rehearse the management of PPH and prevention of PPH. So today we have an expert panel. And so today, Dr. Sharda Jain ma'am, she is the Secretary General of DGF and she is our teacher, a living legend and our mentor for everything. So ma'am, I welcome you. Ma'am has a lot of experience. And Dr. Angila Aneja, who is the President of DGF South, she is an expert today with us for PPH. Dr. Jyoti Bhaskar, President DGF East. Dr. Sadhna Gupta, Madam had been the VP of Foxy, and Madam is a very senior person in the management of obstetrics, and Madam has around 35 years of experience. And Dr. Renu manchanda hasn't joined. She is the Vice President of DGF Northwest, and she will soon join us.
She's already there. She's there with us.
And Dr. Sangeeta Gupta, she is the ex-HOD of the Department of Obs and Gynae, ESI Hospital, and Madam probably will join maybe a bit later. So I welcome you all the experts. I hope I have not missed anyone's name.
No.
And over to you, Dr. Jyoti Bhaskar.
Close the door.
So thank you so much. And I think this particular topic always reminds me of Taj Mahal, because Taj Mahal actually signifies a lot of things, and for us obstetricians it signifies PPH, how we can prevent the death of PPH. And I remember Dr. Angila and me had once done a small dance drama on Taj Mahal, and that is what happened, that Mumtaz, she died because of the PPH in the end. So this is what we all have to prevent. This is all we are here to be able to discuss, imbibe, implement, so that not a single woman on this in our country should ever die of PPH. And we are very, very lucky today, and I would say we are indeed honored to have Dr. Sheela Mane as a speaker today. She's known as a PPH lady, and the first encounter that I did have was, I think, about 10 years back when she had worn the NSAG garment for the Noida Authority, and she had shown us that particular garment and spoken so strongly that it really motivated me at that particular time. Yes, I need to take a stand myself in my practice, not to let a single woman die. So just reading out, we all know her very well, but just to complete the formality, she's currently the DNB faculty at KCG Hospital, Bangalore. She's an ICOG governing council member, and she's standing for the post of vice president of the ICOG. The elections are on, and all the members, all the fellows, please do vote in favor for her. She's the president Isopod Society Bangalore, president Bangalore Menopause Society, more than 2 decades of working for Foxy, vice president for 2014. She has served as teacher for more than 30 years in different colleges and academic par excellence. Recipient of the Best Teacher Award for Dr. B.R. Ambedkar Medical College. She's been awarded, decorated by several awards. And the main, I would say, the hallmark of the USP is the way she tends to speak so passionately about the PPH that each one of us who's a listener tends to get highly motivated to really implement it in their lives. And I have known her because of the menopause exam that we had taken. She had been the main person organizing the particular exam. And the way she actually motivated us at that particular time, at this age also, we managed to study and to be able to pass that exam. So the floor is all yours, Dr. Sheela Mane, and we're here to listen to you.
Yeah, thank you. Thank you for all those kind words. And I'm so excited. That too, Madam Sharda Jain has requested and asked me to speak. That itself is a very big honor for me. Thank you, Madam, and thank you, Delhi Gynae Forum, for giving me this opportunity. So my talk today is on PPH, steps and system matters in management. I think all of us, we know how to manage PPH now, but still we are facing problems. So let us all collectively discuss that what best we can do. And our colleagues are facing problems, and in country it's causing a lot of chaos because of that. So this
can I request you to make it full screen, please?
Yeah, please, I'll do that.
Yes, ma'am.
Yeah. Is it okay now? Yeah.
It will come.
Is it fine? Yeah.
No, it hasn't been.
It is not yet coming. Madam, please click the wine glass little harder. I think it will come.
It's still not the full screen.
Madam, you can go to slideshow otherwise.
Yeah.
And you will not be able to see us for some time when you're presenting. Don't worry.
Yeah. Is it seen now?
Yes. Now it's not
yet,
so small.
ma'am. Not yet, ma'am.
Not yet, it says. Slide show madam.
हाँ जी मैम स्लाइड शो क्लिक कीजिए and from beginning कर दीजिए. Yeah.
Is it okay?
No, it's somehow not coming. Never mind, ma'am. Let's continue.
But we can start with this.
Okay, I don't know what is happening because I clicked down also.
That's
Then
okay.
slide also.
Yes.
Never mind, ma'am.
Okay, steps and system matters in management. So, introduction. All of us, we know that PPH affects approximately 5% of all birthing women.
Slides are not moving.
Now,
No, they're not moving on our screen.
and some problem with it.
Yeah, maybe it's got
I
stuck.
really don't know what is happening.
The madam has to click every slide because this is not a presentation. This is not a slide.
Ma'am, please click on every
Click
slide.
on every slide. It will come.
Okay.
Ma'am, please click the slide which you are talking about.
Now,
Mm-hmm.
No, it is not moving.
Madam, you have to click the individual slide.
okay, got it.
Yes. Now
yeah,
it's
yes,
moving.
yes.
It's moving.
Then I have to go to next slide.
Yeah, ma'am. Yes.
Okay. Because it's not a slideshow for you.
Yes, exactly.
Yeah. So all of us, we know that the PPH affects 5% of all birthing women, leading cause in low-income countries and in our country. What is important is that there are 10 near misses for every maternal death due to PPH. So we also have to look at those near misses. So improving clinical skills, knowledge of the risk factors of PPH are instrumental in preventing mortality as well as morbidity. And all of us are aware of the goal of SDG goal, that is by 2030, the maternal mortality should be 70. Now, the common preventable errors. So today I am talking to a gathering who all are experts. So we have to look at this, that in spite of knowing why PPH is still occurring and why are we still losing mothers. So these are the common and preventable errors. That is under recognition of the blood loss, lack of appropriate attention to clinical signs of hemorrhage and associated hypovolemia, failure to act decisively with life-saving interventions, and failure to restore the blood volume in a timely manner. So I think these 4 points are very important, and that is what is causing the problems now. Now, definitions, I don't think I have to really go into the detail, which all of us we know what is primary within 24 hours, secondary within 6 weeks, and minor PPH is 500 to 1000. Major is more than 1000 ml. Again, major can be divided into moderate, that is up to 2000, and more than 2000 ml becomes a severe postpartum hemorrhage. For clinical purposes, any blood loss that has the potential to produce hemodynamic instability should be considered as PPH, because an anemic woman can bleed less, but still we may find her hypovolemic. Now, massive obstetric hemorrhage is very well defined as a blood loss from uterus or genital tract of more than 1500 ml, or a rate of blood loss of 150 ml per minute, or 50% blood volume loss within 3 hours, or decrease in hemoglobin of more than 4 gram per deciliter, or acute loss requiring transfusions of more than 4 units of packed cell transfusion, or any hemorrhage associated with hemodynamic instability. I think it is very important that people understand this, because most of the time it happens that they are not able to assess the blood loss. Etiology, all of us are aware of the 4 T's, atony being the commonest, and coagulopathy remains still the last thing. Now, the tone, it could be a previous history of PPH, multiple pregnancy, grand multi, fetal macrosomias, polyhydramnias, failure to progress in second stage of labor, prolonged third stage of labor, associated fibroids, and general anesthesia. Trauma, yes, operative deliveries, perineal lacerations, episiotomy, even during cesarean, there could be a trauma like a broad ligament hematoma and extensions. Then retained placenta and placenta accreta, which is again becoming a nightmare for us, and thrombin, that is preeclampsia, HELLP syndrome, bleeding disorders, sepsis, and certain drugs if the patient is already on. So there are three broad areas in which the outcomes from PPH may be improved. One is prevention, which all of us know. Then comes the treatment and the rescue. Now, prevention covers antenatal strategies also. During labor, active management of third stage of labor and the treatment of retained placenta. These are all preventive measures. PPH treatment covers both medical and surgical, and rescue therapies include intravenous fluids and blood transfusion, coagulation correction, and supportive care such as a compression garment. Now, this is the histogram of blood loss at delivery showing the death zone at a loss of over 40% of blood volume and the three strategies for intervention. So that is, first is prevention for everybody. Then once the patient is bleeding, it is the treatment. And once it is a major blood loss, we have to do the rescue. Otherwise, we know that we are going to lose this patient. And this data was adopted from HOG 58 with corrections to the published data. Okay. So what we have learned now that unless and until we prevent, again, we cannot reduce treatment in time and rescue, which is very important. Now, when we come to prediction of PPH, we always talk about that, but we have to talk about each step. Antenatal risk factors, previous PPH, retained placenta, maternal anemia. We are talking about anemia mukta Bharat, but still 20% of anemia contributes to maternal mortality, maternal age, 35 years or more, body mass index. Again, obesity is becoming an epidemic, more than 35 kg per meter square, grand multipara, antepartum hemorrhage, over distension of uterus and pre-existing uterine abnormalities. So we should assess all that antenatally. In labor, induction of labor, prolonged first, second or third stage of labor, secondary arrest of labor, especially in multigravida patients, use of oxytocin for induction of labor, precipitate labor, operative delivery or cesarean section. And as the incidence of cesarean section is going high, I know that even the incidence of PPH is going high. And if we look at the medical legal cases, what we have learned, the maximum cases of medical legal cases in obstetrics are due to PPH, and that PPH during cesarean section. So prevention of PPH, a patient safety bundle is set of straightforward evidence-based recommendations for practice and care processes known to improve the outcome. Now the consensus bundle on obstetric hemorrhage is organized into 4 action domains. And these action domains are readiness, recognition and prevention, response, and reporting and system learning. So these are the 4 action domains. That is again readiness, recognition and prevention, response, reporting and system learning. And there are 13 key elements within these 4 action domains. Now readiness, yes, every unit. We should have a hemorrhage card or a PPH drug box, checklist with instruction cards for intrauterine balloon as well as compression stitches, immediate access to hemorrhage medications, then establish a response team, that is whom to call when help is needed. The blood bank, advanced gynecological surgery, we may have to call an oncosurgeon or a urologist or somebody else who can come and help you. Other support and tertiary services like a HDU and ICU. We have to establish a massive and emergency release transfusion protocols. When we talk about that, we have to see to it that the tertiary care centers or a big obstetrics units who are handling a bigger load should have a type O negative blood, because we do not wait for cross matching. We can give uncrossed matched also when the patient is in class 4 hemorrhage. And unit education on protocols and unit based drills, and we should do the post drill briefs, which will definitely help us to improvise our own system. Recognition and prevention, which is for every patient. Assessment of hemorrhage risk antenatally on admission, measurement of cumulative blood loss, formal as quantitative, and active management of third stage of labor, which is equally important. Response, every hemorrhage. We should have a unit standard stage-based obstetric hemorrhage plan with checklist and support program for patients, families, and staff. And I think with today's scenario, the number 10 point becomes very important, because we'll have to talk to the families, we will have to explain them everything, and we'll have to tell them the situation of the patient. Reporting and system learning again for every unit. So we have to establish a culture of hurdles for high-risk patients and post-event briefs, every patient, every case. Multidisciplinary review of serious hemorrhages for system issues, and monitor the outcome and the process metrics, even in perinatal quality improvement, and that will go a long way. Readiness domain includes 5 areas of focus to be addressed by every facility to prevent delays and prepare for the optimal management of obstetric hemorrhage cases. So readiness aims at improving the interdepartmental coordination. So the hemorrhage cart, all of us know that what it should contain. Now added on is the carbetocin, which all of us are aware now that we have a heat stable carbetocin and which can be used and which is really giving a good results. So we should have a hemorrhage cart. We should be ready with all this, because it could be trauma also. Most of the time the trauma is missed. So we should have a traumatic PPH tray also ready with vaginal retractors, long with speculums, long instruments, needle holders, scissors, Kelly's clamp, sponge holders, even intrauterine balloon, a bunjo curette, which is a big curette, brisk, task, light, and procedural instructions too. Again, a readiness for cesarean, for laparotomy, for hysterectomy with suture materials, and we should have every suture material ready, even for beeling suture, intrauterine balloon, which we can use even during cesarean, and procedural instructions also should be there. Suppose if there is a junior person, then he can go through that for even arterial ligation. Now, to establish a response team, determine who will be the part of the core response team, the maternity care provider, nurse, clinicians from anesthesia, transfusion service, pharmacy, gynecological surgery, advanced surgery, critical care medicine, and the main operating room, even interventional radiology, and additional nursing resources. Use readily available phone or pager number or a rapid response or code system is in case for an emergency. And I always used to say that let us have a H code for hemorrhage in labor room. We have code blue everywhere, everyone will come running. So we should have a H code or some code where the people know that there is a woman who is bleeding in the nursing home, and all the seniors already told that BPH can kill the woman in half an hour, in 1 hour, and within 2 hours. So all of us have to be really on our toes. Establish massive and emergency release transfusion protocols, because it facilitates rapid dispensing of RPCs, plasma, and platelets in a predefined ratio intended to preclude the development of a dilutional coagulopathy that can result if a significant percentage of the patient's blood volume is replaced with large quantities of crystalloids, colloid, or RBCs only. We have not realized, and we just go on giving this, there will be a washout phenomena. Now, as volume is replaced, attention must be paid to coagulation parameters, platelet count, and metabolic status, because very soon the patient can go into acidosis. We have a HDU, ICU. We should look at the ABG also to know whether the patient is in acidosis. We have to look whether the vital lines are stable, alert the blood bank for possible need. If there is tachycardia, we should immediately transfuse to PRBCs and order cross-batch for further units and consider FFP. If there is hypotension, activate massive transfusion protocol and not to wait. Now, carbetocin, I just mentioned, all of us, we know about the Champion trial now, but still evidence base says that it is used only for active management of third stage of labor, is been recommended for India. Okay, so that is about carbetocin. All of us must have had lot of seminars and webinars for this, and all of us, we know, and we have the practical experience also, and we know from Champion trial that it is useful. So that is about carbetocin. Now, the thing is, there are no national guidelines for activating the massive transfusion protocol. The criteria are varied and include when patient is actively bleeding and any of the following if it is there, like systolic blood pressure less than 90 millimeters of mercury, pH less than 7.1, base deficit more than 6 milliequivalent per liter, temperature below 34 centigrade, INR more than 2, and platelet count less than 50,000 per cubic millimeter. You have to ask the blood bank to issue 6 units of PRBC, 6 units of FFP, and 6 units of platelets, and to keep 10 units of cryoprecipitate ready, as the patient will have afibrinogenemia. Now, the hemorrhage drills. A drill refers to a clear and logical steps involved in the patient management. All team members should be familiarized with the entire safety bundle and new management plan. Participating members are assigned tasks and responsibilities necessary to run the drills, and the post-drill debriefing provide an invaluable opportunity to learn from the experience, specifically to inform the areas of drill that went well, discuss areas in need of improvement, share the lessons learned, and highlight the system issues to allow for concrete planning for potential solutions. Drills may be combined with practicing infrequently used hemorrhage technical skills like placing a tamponade balloon or the compression suture using simple aids. Coming to recognition and prevention, assessment of hemorrhage risk. So identification of risk helps to improve the readiness, allows increased surveillance, early recognition, increase the use of preventive measures, and prepare the team to initiate an early aggressive response to bleeding. Risk assessment should be considered at multiple time points during patient care, antepartum, during labor and delivery, and even late in labor and after delivery. Now, these are the parameters to be assessed. The vital parameters, all of us we know: pulse rate, blood pressure, respiratory rate, systolic blood pressure. If it is below 80, is associated with worsening tachycardia. Rule of 30 we can apply where there is a fall of BP by systolic blood pressure by 30 millimeters of mercury, increase in the pulse rate by 30, hemato output less than 30 ml per hour, and hematocrit also if is less than 30, then acute amount of blood loss has to be more than 30% of blood volume, which falls in class 3 hemorrhage. Shock index, which is another simple clinical parameter to assess. If it is more than 1, it indicates that the patient is in shock. We have this chart where we assess. Now, why do we say assessment of that clinical assessment by the shock index? Because in class 1 and class 2 hemorrhage, there is hardly any difference in the patient's vital parameters. Only when she reaches class 3, you will find there is fall in BP and profound tachycardia. But if we look at the shock index, we will know that the patient is into hypovolemia, and we can start the corrective measures early. Because in class 4, we know that the patient is sinking, and we will have to ask for massive transfusion protocol initiation. Now, the risk assessment, we have already discussed. Very important to know whether it is adherent placenta, the BMI, clinically significant bleeding disorder, may be rare but still, and other significant medical and surgical risks. If the patient has undergone 2 cesarean sections or other surgeries, there could be adhesion, she could be obese. On admission, we have to assess whether there is a medium risk or a high risk. Medium risk is prior cesarean, uterine surgery or multiple laparotomies, multiple gestation, more than 4 prior births, prior obstetric hemorrhage, large myoma, estimated weight more than 4 kgs of the baby, obesity, BMI more than 40, and hematocrit less than 30%, and other risks. Now, high risk is placenta previa, low lying, suspected accreta percreta, platelet count less than 70,000, active bleeding, known coagulopathy, and 2 or more medium risk factors will become high risk. So that is how we should be assessing the risk. That is again on admission. Intrapartum medium risk is chorioamnionitis, prolonged oxytocin for more than 24 hours, prolonged second stage, and if we have given magnesium sulfate for preeclampsia or eclampsia. High risk, new active bleeding, again 2 or more of medium risk factors from above, and on admission and even on intrapartum. So that is how we will have to assess the risk. Now, measurement of cumulative blood loss is a visual estimation of blood loss, sometimes called a glance and a guess, is common practice, where all of us we know that most of the time we underestimation of blood loss by 33 to 50%. So direct measurement of blood loss can be accomplished by 2 complementary approaches. The easiest to initiate is to collect the blood in calibrated under buttock drapes for vaginal birth or in canisters for cesarean birth. Second approach is to weigh the blood-soaked items and clots and weigh of dry pads and subtract from the total weight to obtain an estimate of blood loss. And I think if we really start practicing, that really works. We should also have these type of charts, because we use so many times simple swabs for episiotomy, and even, so many soaked 10 times, if you have a 10 centimeter into 10 centimeter will become 600 ml. medium size 30 into 30, 140 ml, large 45 into 45, 350. 1 kg soak swabs is 1000 ml blood loss. Kidney full dish full of clots is 500. 50 centimeter floor spill 500. 75 centimeter 1000. Like that it goes on increasing. So if we have these charts will also help us in assessment of blood loss. Active management of third stage of labor, I don't think I have to really talk because all of us are masters now. And intervention. This is the WHO recommendation. That is about the active management of third stage of labor, which we are already aware that we have to practice the everything. Cord clamping, we know when to do, and all SDAs are trained for that, and they should practice in each and every patient. Response, every hemorrhage. Obstetric hemorrhage emergency management plan, a critical initial step is to determine the etiology. Hello?
Dr. Mr. Ajay Malik, can
Please
you
unmute,
please...
Marti, please unmute the...
Hey, mute. Mr. Ajay Malik, can you please mute yourself?
Stage-based management plans have been found to facilitate and organize stepwise response to blood loss and maternal warning signs. So I think these Meow signs are still hold good, and we have to really teach our staff in the labor room to monitor that way. They ensure that the resources are not wasted while each patient receives optimal therapy. Each institution needs to adjust the plan to meet its individual capabilities. So response team is very important, and that means not only the higher consultants, everybody in the labor room should know what is the response they should have when they see. That depends again on the class of hemorrhage. Class 0, yes, where everything is okay, you have assessed the risk. If she is high risk, you have kept the blood ready. If she is low risk, you have just typed and kept it ready. In stage 1, where the estimated blood loss is between 500 to 1000 ml, we will cross match and keep 2 bottles ready. But we know that we have to start a big bore cannula, give fluids 1:3, and you do all other measures to control the bleeding, whether massage, aortic compression, or taking care of trauma. Stage
Marti,
2,
please unmute the person whose phone call is going.
then if stage 2 is where the patient continues to bleed with excess blood loss, all the other measures.
I am not aware. Marti, please
unmute.
Please mute yourself, please.
I'm not aware what is happening.
Marti, please mute the person.
Marti may not be able to, but...
So in stage 2 hemorrhage, again we know that we have to act fast. We should get all the tests done. That is the coagulation profile done. Okay, PTA, PTT, if possible fibrinogen. Vaginal birth, repair tears, rule out retained placenta. We can put a balloon also if it is a atonic PPH. Selective embolization if the facilities are there. Okay, we should be, see to it that we have to keep everything ready. Yes, if it is a cesarean, we can do compression sutures, stepwise devascularization, ligating the vessels in the placental bed. All that can be done. Even you can repair if there is a uterine rupture, and last resort will be hysterectomy. But consider transfusing as per clinical signs and not wait for lab values is the lesson. We don't, I think I still prefer doing a clot observation test because, the blood report will definitely take. Immediately transfuse 2 to 4 and check the availability of additional RBCs and coagulation products. In stage 3, you have to activate MTP. We discussed already that we have to arrange 666. That is PRBC, platelet, and as well as the FFP. We should have a central line. You should have inform the family, the support, the surgical management, and supportive compression stockings to be applied to the patient, which will definitely help. Even if you are shifting the patient from the labor room to OT, you can apply the anti-shock garment and shift the patient because that will definitely help. And transfuse aggressively. That is the lesson, you should not wait for anything, for any investigations, as you know. Then the support program for patients' families, women and their families need timely information, reassurance, and opportunities to discuss the incident with the maternity care provider. Then reporting and system learning. So we have to establish a culture of hurdles and debriefs. It has to be routine. Multidisciplinary review of serious hemorrhages. And the purpose of these reviews is to identify the system issues or breakdowns that influence the outcome of the event. Reviews should be sanctioned by the facility, protected from discovery in legal proceedings, and include a thorough record review, event timeline, and focused root cause analysis. And monitor the outcome and process metrics. It is important for the successful introduction of quality improvement projects. The overall goal is to reduce the number of obstetric hemorrhages that escalate into major blood loss, resulting in severe maternal morbidity or mortality. Now, all this is happening in bigger units. What I feel, the problem is there where in smaller nursing homes where they face the problems and they are not able to act in time and take the decisions, or they don't have the, habit of doing the debriefing. Now the technical skills, that is improving clinical knowledge. We know that we are going on doing these trainings. That is UK prompt training also was done. Then standardized course also include MOET and others. Evidence-based memory aids can be taught to facilitate recall of the fundamental treatment steps in PPH and have been shown to reduce the chances of peripartum hysterectomy. So the importance of communication among the membranes of the MDT should also be emphasized, which also plays a very important role. And obstetric emergency simulation training. Non-technical skills are very important because we have never learned that. That is communication, teamwork, and leadership. Because leadership matters a lot, because the leader has to play a very important role. The leader has to have a helicopter view of the situation so that the leader can give orders, and his orders should be, the voice should be heard, and you should specifically tell that so and so you do this, so and so you do this, give this much of carboprost, 250 microgram intramuscularly, and that person should repeat. And everything goes on and there is no chaos in the labor room. So individual medical professional, again the knowledge and experience matters. The patient is in the center. So the expertise, situal awareness, communication skills, and understanding of the team members. Then comes the multidisciplinary team, where is allocation of a leader, delegation of tasks, appropriate team members, and a closed loop communication and flattering of hierarchy, which is very important. Infrastructure, you should have a major hemorrhage protocol, auxiliary staff, okay, even porters, access to equipment, local guidelines, and emergency services should be available. Simulation training again should be made available of technical skills, non-technical skill, even improving communications, improving team learning, and knowledge of local protocols. Again, assessment, which we have already talked about. So all this becomes very important. So the prevention and management, home birth, it is not now because most of the time it is, we don't have to do, but still the ASHA workers are provided with misoprostol tablets. The ambulances are given the anti-shock garment so that when they are shifting the patient, at least they can make the woman swallow that 3 tablets of misoprostol till she reaches the facility and the anti-shock garment is applied. Now, this is the management of PPH at different levels of care in low resource setting. So it could be a clinic or a CSC, okay, or a basic emergency care if they are providing. Then there is only a nurse, a midwife, and a clinical officer, only one doctor, okay. And the district hospital, you may find a midwife, clinical hospital, and a general doctor. And so many times the specialists are not available. Then the resources, the 24 hours delivery facility is there in these BMOC facilities. Resuscitation, they can do fluid resuscitation with crystalloids, they can monitor the vitals, they can apply the anti-shock garment and refer the patient. Treatment, they can do bimanual compression, aortic compression, give more oxytocics, immediately give tranexamic acid also. If there is a simple tear, they should repair, otherwise pack and send. Manual removal of placenta, as there is no anesthetist available, they can't do it, they may have to repair, they may have to refer, and the balloon tamponade, they should be taught even at a level of when they are giving basic emergency care. In district hospital, there could be a delivery facility plus inpatient stay, and they have a blood storage facility they should have. They should have an operation theater, a fluid resuscitation, blood transfusion, at least group specific, and they should have, if possible, the FFP as well as platelets available, NSG for referral, injectable prostaglandins, all oxytocin should be available. It should be able to repair the cervical tear, able to do the laparotomy for compression, and if required, they may have to do hysterectomy also. Tertiary care, again, COC, that is midwife, these are all related to public facility. They should have a blood bank, operation theatre, even a radiology department, intensive care unit, fluid resuscitation, blood transfusion, emergency and cross-match blood, and frozen plasma and platelet, and ventilatory support should be there, and facilities for all the emergencies, like if patient requires hysterectomy and all that. Non-pneumatic anti-shock garment, all of you know, and our personal experience also, that it really helps even in tertiary care centers as it reduces the blood loss. I don't have to tell this August gathering about that. All of us, we know. So even that can be used. I would like to just talk about this e-motive implementation project, which recently WHO has started. This is a PPH bundle to enhance the guideline adherence and to improve the maternal outcome in PPH. Okay, this is started by University of California, San Francisco, and WHO is joined with that. And I have heard about this even from Professor Arul Kumaran. So what is that they are doing in e-motive is, this was PPH, why despite technology interventions, increased facility births, published guidelines, where too many women still dying from pregnancy and birth. So they have found there is lack of dignity and respect. All of us, we know about RMC, that is respectful maternity care is must for everybody. Lack of early recognition and early action for complications, and there are delays, and lack of adherence to evidence-based care promulgated in guidelines. That is what they have found this. So this is again, response was the collaboration that becomes the e-motive project. So what is e-motive is, M is for massage, O is for oxytocin, T is for tranexamic acid, IV is for IV fluids, and E is estimation of blood loss. And this is designed to address the challenges to implementation and adherence to evidence-based PPH guideline by using a bundle approach. So that is the e-motive project. So I would like to thank everybody for patient hearing. An ounce of prevention is worth a pound of cure, was said by Benjamin Franklin. And I think today the day has come. All of us are experts in managing, but we have to really gear up, and we have to gear up everybody in the country to act in time and take decisions appropriately and to practice evidence-based medicine. Thank you. Thank you very much once again for the opportunity.
Thank you. Thank you so much, Dr.
Dr. Sadhna, your comments? Dr. Sadhna.
Thank you. Dr. Sheela Mane has been like one of the person who has been I have seen her as a mentor, and we have like developed as a twin face for safe motherhood in Foxy. And we both have a tough time also in Foxy. Secondly, we'll just take this opportunity to thank Dr. Sharda Jain and the whole DGF for being so supportive in last few months. And what we say that it is not win, not lose that matters. It matters how good and dedicated people we get know to and how they add to our lives. So this is the moment when I have to pay a great thanks to Dr. Sharda Jain and the whole DGF and all the members of AOGD. About the PPH, we say it is a topic which is aching our heart today. And it is actually like we have been all in chaos. And one thing what we say, and I will say the last thing first, that when we talk of leadership and everything, actually what I like have a little change in my approach also, to be very truthful, that once upon a time we had a pulseless, BPLess, whatnot, but we were leaders. But at this moment, we have to divide leadership into two parts. What is the response? They are cooperative or not cooperative, they are bringing blood or not blood. So this is the thing which is actually how the people's behavior actually changes and how they criticize. And we want to sometimes the people say refer it early, because even though they have the facility. So we have to be look forward that together, and we have to be supportive to all of gynae, whether they are working in remote area, whether they are having one single attribute, because that is really crippling. Now a little bit about the subject. One or two things, a wonderful lecture by Dr. Sheela Mane about the systems, how we should evolve in the system, and we have come a long way in active management of third stage of labor. The things were quite different around 2003 when there were diverse practice for active management of third stage of labor. Oxytocin was not kept in the fridge, and we have really come a long way. One or two points just I want to highlight. I think all people know it, but one thing is when you are using carbitocin as MTSL, then for management oxytocin is not effective. So this is very important. Still the anesthetist also put oxytocin, and many people are using oxytocin 20 to 40 units. So one thing is very important, that is key change. Carbitocin is a very effective drug, wonderful drug for active management of third stage of labor, but no additional oxytocin is needed either for prevention nor for management. We have to switch to other oxytocin agent like DGF2 alpha or misoprostol. Second thing, which is that for elective cesarean, now we are having a load of elective cesarean section because of previous section. In that, carbitocin is the drug of choice because elective cesarean patient is not having any endogenous oxytocin, and the carbitocin very effectively joins with the oxytocin receptor, so it is very good drug. And when we have the myoma, don't switch to remove every myoma. Be very careful which myoma is to be removed and which myoma not to be removed. And one very important observation and the research which is actually we want to share, that especially in a high risk situation, high risk PPH case, fibrinogen estimation just before delivery, around time of delivery, is one of the very good predictive marker for the postpartum hemorrhage. And if in pregnancy it is less than 200 or around 250, then it is almost 98 to 100% predictive of PPH. So we are doing coagulation profile, we are doing prothrombin time, liver function, kidney function test, but especially in high risk antenatal risk factor, I think we should think of measuring fibrinogen level also, so that we can really predict that this patient is going to have some sort of moderate to severe PPH and where she should be delivered. And the fourth thing, that we know PPH can be unpredictable. Let us people also know and imbibe the fact that PPH is unpredictable. This is very important today, especially very highly educated class, IT class. They fail to understand that the childbirth is interlinked with the risk factor, and they fail to cooperate with the thing how they are ready with the mobile photograph, they are ready with the celebration, and once we tell them the patient is having PPS, they are not at all mentally ready. So these are the few things which is in the our society we have to be careful. Few things in our new drugs, we have to understand the new drugs and the new situations very well, and don't go to doing all myomectomies and I am doing that myomectomy. I also do, but we have to be very careful that which myoma at what time to be removed or it should not be removed. So these are the few comments from my side, and thank you, Dr. Sheela. It is really like a treat and a pleasure to listen to you, and always revise PPH, because we always memorize so many cases of PPH what have been done. So thank you very much.
Recently, Shashi, can I share one thing?
Yes, ma'am.
So recently, Intas company has come with fibrinogen, and it happened that they came and gave me 5 ampoules. The day samples, the day they gave me, I was just thinking, oh, what will I do with this? The very next day, I had a case of antepartum hemorrhage, abruption. Okay. And before I could get her all the investigations done, there was a big clot of 800 ml. 800 ml big clot means definitely the patient has lost a lot of blood. So I immediately gave her one fibrinogen. I delivered it from nursing home to that government hospital. That time I was in Mumbai. For MOX conference I had gone. But I told them to deliver. Then another hospital where I go, the next day another case of abruption came. Okay. And the patient had delivered outside and they had sent her. There was no time. So, and there was hematuria. So definitely she is already gone in for DIC. So I gave her one fibrinogen. After 2 hours, I gave her again one more. So the amount of blood transfusion also she required was comparatively lesser. So what I want to, it's very expensive. It's cost 12,000 rupees. Okay. But I mean, there is a fibrinogen which is available. At least if we can keep some stock, in case of an emergency. And I felt that accidental hemorrhage is the ideal, because we know that the big clot has really taken away all the fibrinogen from her. So that is how. So I have 2 more vials with me now. That day again, one more person called me. She said it is a traumatic hemorrhage. I need it. She sent her driver. And then that time I was in Indore. Then I sent one more. But I think now once people develop confidence, they'll start using it. But whatever points Dr. Sadhna has told about, increasing the incidence of cesarean, even fibroids we see. And obesity has become a real problem, So, and we know that they all bleed more. Thank you.
Yeah. So, what is your message, Sharda ma'am?
Thank you, Dr. Mane, for an excellent talk.
In managing PPH?
And I will just talk on 2 aspects.
I come from UP where the delivery is called Japa. Jaan jaake paate. Very simple. So people know that delivery is a risk for as far the life is concerned. Now, my experience with the Delhi Medical Council and now with the LMC is, as a gynecologist, that may be acceptable to me. But 10 members of the ethical board who are there, the death is not acceptable to them. I'm very clear about it. Death is not acceptable in delivery. So the message is very clear. If you are working in a nursing home, if you are trained well, in 2 hours you must make a decision for hysterectomy. In case she is in a periphery, she must reach the hospital where the things can be done. So what I'm trying to tell you is, delaying what, ye laga do, ye stitch laga do, ye wala kar do, wo wala kar do, everything should finish in 2 hours time.
Yeah.
That may be acceptable to Dr. Sharda Jain sitting at NMC, but that is not acceptable to the 10 people who are sitting there. No, Dr. Jain, she should have exercised hysterectomy. We cannot give her, we can't pardon her. So this is what you must know. All gynecologists must know about it. That is not acceptable. If that is not acceptable, I'm talking of my colleagues. मैं औरों को क्या बताऊं डॉक्टर साहब? मैं अपने colleagues को convince नहीं कर सकती कि डॉक्टर साहब ये होता है. कहते होता है, भाड़ में जाए डॉक्टर साहब. क्यों नहीं hysterectomy करी उन्होंने? ये internal lie, ये सब कुछ जो भी कुछ आपने करा है, primary time when you're doing a cesarean section, you must safeguard everything from every point of view. Take 5 minutes or 10 minutes more. See to it that everything is done. When you leave the theater, patient should be absolutely all right. Don't walk out of the theater. See to it everything is okay. Patient, she's not bleeding. See yourself. Don't believe on the assistant. But death is not acceptable. 2 hours, the action must take place. And any high-risk patient, I think your time has come that in every premises you must write down, delivery means that death can occur. If it is not acceptable to them, let them take anywhere they like. Let me tell you this is the kind of people, action is going to come from the public more and more. Yes, I will like to have more comments as expert, but what I'm trying to tell you, it may look what I have spoken an asset to you, but this is what the reality is.
Madam, I want to make...
Yes, ma'am, Renu.
Thank you, Dr. Sharda Jain. I am working in a peripheral district hospital and we are conducting about 10,000 deliveries. So, from my experience, ma'am, because we are working in a government setup and we have very maternity homes and we get referred cases, I feel that risk identification in the antenatal period and proper referral even in the antenatal before delivery to a center where in-house facility for blood transfusion and surgical is available is very important. If we have to, because the referral, transportation of the patient when she is referred from a peripheral center, there is always delay and the proper transportation is not possible. Maybe sometimes vehicle is not there because of and sometimes they will not inform the institute where the patient is being referred. The institute is not prepared to take such a patient. There is delay at every level. So my opinion is that timely identification of risk factors and referral and preparedness of, like Madam Dr. Sheela has said, that preparedness for any unit which is conducting deliveries is very, very important. And coordination between different, institutes. Like if they are referring, they have to call the person in the hospital where referring, so that adequate measures are done before she arrives in the hospital. Blood is arranged, the ICU is informed, the surgery, OT is prepared. Before even she comes to the hospital, all these things should be prepared. If we are serious, and second thing, my experience is that we were using condom catheter. Condom catheter has given us very good results, but the result is better if the blood loss is not too much. When the blood loss is too much, there is hypoxia sets in, and then the condom catheter also does not work. And recently we have procured Bakri balloon catheters where we can measure the blood loss after. That has proved to be better than the Foley's catheter which we are using. So these are some of the comments which I want to make. We do not have carbitocin right now, but misoprostol orally or oxytocin, and sometimes ergometrin also. If the patient is not hypertensive, then ergometrin is also, even now, is a wonder drug for causing contractility of the uterus. And in such a situation, I think if the patient is only contraindication is hypertension, we can use ergometrin also. It's a very simple drug. So the referral is referral linkages are not properly formed in the peripheral centers, and that is causing delay in the management of the patients.
Thank you so much, Dr. Renu. And now we would ask Dr. Shashi to give her expert comments.
I think Dr. Renu mentioned about ergometrin because ergometrin contracts upper and lower segment both, whereas oxytocin acts only on the upper segment.
Yes.
Also acts on both. But
and secondly, madam, like we have so many cases previously there in section, and if the placenta is a teeter and low lying, then screening for placenta egrita either by using a ultrasound Doppler or MRI in the antenatal period, and if the evidence is there that the placenta is adherent, I feel the patient should be referred to a tertiary center before she goes into labor. Referral is very important.
Sometimes you open up a patient, okay, and you see there is a placenta accreta spectrum, lot of vessels and everything. It's better you stop there, close the patient if there is no distress and refer to a patient. Don't try to open up a patient at a place where you don't have a blood bank facilities or anything, unless the patient is bleeding a lot. Yeah. And second, we are all talking about, I think in last 1 year, I must have attended at least 20 lectures PH. The most important thing is whoever is here should have a protocol, whether we have a protocol or not. One, that should be made. Two, we should start with the drills. That not only you, your staff, your juniors, it should be staff nurses as well as technicians. So that they don't run in different directions when the alarm is raised. So everybody should know what to do and when. And PPH kits has to be ready, which should have everything in it, including your condom catheter or a Chhattisgarh or a Bakri balloon. If you are ready, you won't waste 10 minutes, even 10 minutes into it. And, I will little disagree with Dr. Sadhna ma'am just to do fibrinogen level for high-risk patients, If your coagulation profile is normal, you don't need to do a fibrinogen level here.
Actually, this is a very, very, very strongly powered studies which says that it is 100% predicted, especially in the patients who are having the
the fibrinogen level is not done by every lab. Second, you don't get the results earlier. Three, the interpretation goes wrong so many times. So I think the idea is, yes, you are right. The many studies are saying higher center who want to do it, but the message to the public is, if cognition profile is normal, please don't go into it. But yes,
now the blood banks are having facility for thermoelastography.
Yeah.
Thermoelastography also tells you that you need to give what at what stage.
Yeah.
But again, every institute does not have that facility.
So if they know, the massive average wall, 1:1:1, if they know that, even that works very
Yes.
If you send a fibrinogen level and you get the results after 48 hours and the patient has already died, there is no point acting now. It's better you give fluid and then blood components and resuscitate your patients on time.
And cryo.
That is a different situation.
We can give cryo also.
Yes.
That is different situation where the bedside, what Dr. Sheela said, that
How to save every life in your hospital.
And one more that visual, whatever the doctors are estimating, the blood loss estimation is always less than the actual blood which has been lost. So I always tell my residents, if you have a suspicion of PPH, like you feel that, you should put a condom catheter. There is no, what people I have, observed that the lady is bleeding, they're just checking whether it is excessive or not excessive. Or I always tell them, even if you have a suspicion, you are not going to do any harm to the patient. You just put a condom because earlier the better results it has shown. If the blood loss is already there and lot of blood loss is,
Dr. Renu,
hypoxia sets in and the uterus becomes very flabby. I had one of the case where condom catheter was put, patient was shifted to ICU, but she was bleeding inside. And because it was a fully catheter, they could not monitor. And then they were in a fix whether to remove it, see it again. So all these things delay the actual management which the patient needs. So it has to be, the management has to be really, really aggressive in case of PPH.
Thank you so much, Dr. Renu. I think
I would like to share 3 important points. Am I audible, Dr. Jyoti Bhaskar?
Yeah, you are audible, Dr.
Yeah.
Shashi.
The first thing, that PPH bundle, which is come up in 2020, the meaning of PPH bundle is that you have to use all the modalities of management of PPH within 2 hours. Even Sharda ma'am has especially put emphasis on that. 2 घंटे में आपको सब कुछ करना होगा, जरूरत है तो वो भी करनी होगी. 2 घंटे तक यदि PPH का मैनेजमेंट नहीं किया तो पेशेंट deteriorate. So this 2 options in using all the modalities of treatment, including hysterectomy if required, is very important. और एक बात जो मैं हमेशा कहती हूँ कि saving the uterus and killing the mother is of no use.
Yeah, there is no point in saving the uterus.
Hysterectomy करना बहुत जरूरी है. It should be a quick decision. We should resort to hysterectomy sooner.
Doctor, I'm just trying to tell you what is NMC experience of the ethical committee members. वो कहते हैं डॉक्टर साहब आपने सब कुछ किया, पेशेंट को बचाया नहीं तो कुछ भी नहीं किया.
कुछ भी नहीं किया. Exactly.
नहीं, क्योंकि ना जब आप मेडिकल लीगल उसमें जाओगे, फंसोगे तो सबसे पहले कहेंगे आपने हिस्टेक्टमी क्यों नहीं किया.
यही सबसे पहले.
वहाँ पे शारदा जैन कुछ कन्विंस नहीं कर सकती उनको डॉक्टर साहब.
बिल्कुल नहीं कर सकते.
I will say do a hysterectomy if required to save a woman.
Yes. बहुत लोग
everybody who's listening me, please let you 2 घंटे में जो भी कुछ करना है 2 घंटे में कर लो भैया.
No. और एक बात है, हिस्टेक्टोमी भी किया तो भी you have to transfuse blood and blood products. Operatively, there will be hypovolemia otherwise. If we have not corrected the hypovolemia, she will go in for DIC even after hysterectomy.
Subtotal hysterectomy बहुत fast होती है.
वो तो ड्रिल सीखनी पड़ेगी. But what I'm trying to say, delaying on a balloon therapy, delaying on a lens thread.
Yes.
2 घंटे हो गए तो हमें hysterectomy तो करनी ही है भैया.
Yes.
The only thing I'm scared, is of DIC and placenta accreta. These 2 things से कान बचाए भैया.
डॉक्टर साहब साथ में किडनीज भी चली जाती है.
आने वाला है प्लेसेंटा एक्विटा स्पेक्ट्रम डिसऑर्डर का. We are going to face an epidemic of placenta equita spectrum. And we have to be very proficient in doing hysterectomy and doing other conservative methods of.
But अगर हमने mortality बचा ली and if she has, lot of morbidity, that is also not a very good outcome. Renal shutdown is very common after placenta. And it takes, तो वो भी नहीं है, और जल्दी ही
डॉक्टर मैं आपके सामने बैठी हूँ. I have completed 75 years. Renal shutdown does not happen like this. Sadhna will also say, renal shutdown does not happen like this.
आप डिले करते हैं
कुछ नहीं होता इस तरह की चीजें.
एब्रप्शन में सिर्फ एब्रप्शियो प्लासेंटा में जल्दी हो सकता है. Otherwise, due to blood loss, it doesn't happen so.
But मैम क्योंकि अगर fluid replacement proper नहीं करा है, तो मतलब that is the main thing. If the management of fluid resuscitation is not there, then the patient can have renal problems.
We have other expert. Dr. Sangeeta is here.
No, ma'am, Dr. Sangeeta is not there, so I'm going to be joining. I think I'll take the last word if that's okay, and then we finish.
Yes,
Even I have to go for an emergency.
I think it was an excellent discussion. At the end of it, we have spoken all aspects, but only one thing I would say in the end, that we need to remove the fear. The moment we see the uterus trickling down, every obstetrician gets so fearful, and because of that fear comes the denial. Nahi, kuch nahi hoga, sab theek hai, I can manage that. And with that denial, we make all the mistakes, because at that particular time, with fear and denial, we do not do it. So as obstetrician, the most important thing is we need to accept that PPH can take place, that if there is a PPH, I am well empowered to be able to handle it. And if I'm not feeling too good about it and handling it, call for help immediately. Call your colleagues, call your seniors, call anyone you can. Everyone will come to help you out, because it's ultimately the patient and you who needs to be protected. So let's really take from the learning, go on with the drills again and again, learn every
And
aspect.
that shock index should not be forgotten.
Yes, madam.
That should not be forgotten.
Train everyone, man. Train everyone in your
Madam,
hospital.
blood loss estimation, shock index, not to forget tranexamic, give it immediately and do all the measures. I think that will, and if patient is high risk in small nursing home, don't do it alone. Take one more competent assistant and do it from the beginning itself. Not to do it with a junior. We don't lose anything. So from the beginning, because if we are having that fear factor, at least our assistant will be able to guide us and take a proper decision.
Dr. Mane here, I must tell you, after leaving the four walls of the medical college when I came into practice, Dr. Kotwani was here. So we had gone to Bangalore for a prostaglandin workshop, and I was speaker there. She was sharing my room next door to me. So मैंने कहा डॉक्टर टिप दीजिए, तो उसने कहा 4 walls of medical college में तूने क्या किया, इसका मतलब नहीं है. यहाँ पर आपको इक्वली कॉम्पिटेंट पर्सन सिजेरियन के लिए भी रखना पड़ेगा अपने सामने, और इक्वली कॉम्पिटेंट पर्सन हिस्टेक्टमी के लिए रखना पड़ेगा. दिस वाज द टिप गिवन टू मी बाय सच अ सीनियर लेडी फ्रॉम दिल्ली, एंड दिस इज व्हाट इट इज. सो वेयरएवर आई वर्क, आई ऑलवेज टेल देम, 2 MD असिस्ट करने चाहिए एक दूसरे को एज फार एज सिजेरियन सेक्शन इज कंसर्न. लोगों को बुरा लगे, बट मैं कहती हूँ नहीं, आपके सामने एक असिस्टेंट MD वाला होना चाहिए. And that people. कई बार लोगों को बुरा लगता है कि मैडम questions that why the second assistant was not an MD doctor. But I think it makes difference. It is a question of life and death.
Yes.
And that is what I learned from Madam since I joined her. Madam, I have known her as a professor and a person surgeon par excellence. Yet she would take some MD, Dr. Jyoti Agarwal, or anyone with her, and used to always bad. But then I realized I think that is the most safest way to do, and I try and follow her steps always.
See, as you become more senior, the safety plays a very important role. You should see to it that you go home back and you can sleep,
get a good sleep,
peacefully. That you know that your patient is not bleeding, she is not going to bleed anymore, and you have taken proper care.
Yes.
I told you the other side of the picture is death is not acceptable to the society. Death is not acceptable to fellow people also. So you have to see to it, whatever you may do, it has to be within those safe time.
Yes. Those 2 hours are very, very important.
So
thank you, Dr. Mane. Thank you, Dr.
Thank you, madam. Thank you. And requesting everybody, those who have still not voted, please open the link and vote for ICOG Vice Chair.
We voted.
Yeah, thank you.
I voted.
Thank you.
We
So good night
voted
to
all.
everyone. Thanks to everyone for joining.
Mm.
Thanks to Dr. Sheela, Dr. Sharda Jain, Dr. Sadhna, all the experts and all the colleagues who have joined in at the night. So let's sleep well tonight. We've studied hard.
Thank you. Thank you so much.
Bye-bye.
Thank you so much.